Good morning, everybody. Welcome to our lab values and ABG crash course here. We're going to be spending 2 entire hours focused entirely on these must-know NCLEX numbers, what they mean, how to interpret them, and really just that core content that you've got to know for the NCLEX. Of course, then interpretation of ABGs, what they mean, when you might see those results in your patients, etc. So the first about hour of the course, we're going to be going through those different lab tests that we run in the hospital, at the clinic, the results that we see, and what they mean. I'm a really big proponent of always understanding what you're valuing, what you're evaluating, what it means. It's one thing just to memorize content and try to regurgitate that on a test, but it's pretty hard to pass your NCLEX with only memorization. Yes, you need to memorize these numbers. It's great to make some flashcards to do that. But if you don't know what they mean, what patients might present with those values, and what that tells you about your nursing interventions and treatment plan for that patient, you won't really be able to critically think through those challenging NCLEX questions, and chances are you're not going to get that pass result that we so very badly want you all to achieve. So let's get to it. Let's get into these lab values. The very first set that I would like to discuss with you guys, probably the most commonly run test throughout hospitals across the globe. Whoops, my screen flipped, so sorry. A complete blood count. You'll hear nurses call this a CBC. So it's exactly what it sounds like. A complete blood count gives us the count for all the different types of blood cells that we have in our bloodstream. We have red blood cells, white blood cells, and we also have these teeny tiny cells, platelets. So let's talk about each of them. First and foremost, red blood cells. What do they even do for us? Well, they have this nifty protein inside of them, hemoglobin, and that transports oxygen. Oxygen latches onto that hemoglobin, blood flows throughout your body and delivers that oxygen to your tissues. Of course, it's also going to be bringing nutrients like glucose. Our cells need glucose for energy. Electrolytes. It's going to be helping to clear away toxins, urea, nitrogen, carbon dioxide, and bring it to the respective organs that are going to help us get rid of those toxins, bringing CO2 to the lungs, bringing urea and nitrogen to the kidneys so that they can get rid of it, right? So blood is the flow of all of that throughout the body. With red blood cells, we're really specifically looking at that hemoglobin and the transport of that oxygen. Okay, so the first two numbers you're going to see on a complete blood count are, I'm going to refer to as your H&H, your hemoglobin, and then your hematocrit. Let's talk about your hemoglobin first. Like I said, it's that protein, remember, binding to oxygen, carrying that out to your tissues. And we're going to monitor how much of that hemoglobin is present in your patient's bloodstream. Normal values here. This is the only one that I'm going to show you that has a very different normal for males versus females. And you are going to want to know that difference, okay? So for males, we like to see our hemoglobin value about 14 to 18. And for females, about 12 to 16 is going to be our normal range. We really worry when our hemoglobin value gets lower, because then we're not having enough oxygen transport out to the tissues. We don't have enough of that protein hemoglobin to bring oxygen out to the tissues. And that's when we say that our patient is anemic, when they don't have enough of that hemoglobin. We have anemia. Now let's talk about the hematocrit. You'll notice this is in a percentage. So this is really showing you the ratio of the volume of red blood cells to the total volume of blood that we have in the body. So it's going to be directly correlated to your hemoglobin. A lot of times you'll notice that your hematocrit is about 3 times what your hemoglobin is. So for a female, if they have a hemoglobin of 12, I would expect that their hematocrit, give or take, of course, is around 36%, okay? So females, our hematocrit normal is going to be that 37 to 47%, and with males, 42 to 52%. Of course, because these are directly correlated, we'll expect that normal value to be a bit higher for our male patients. And that brings us to our red blood cells. And that number, super straightforward, the number of red blood cells that we have in circulation. Normal is going to be 4.5 to 5.5 million. We have lots of red blood cells. And again, we worry when that number is too low, indicating anemia. Okay, the second type of cell that we're going to be looking at in this complete blood cell count, this CBC, are the white blood cells. And you all know our white blood cells are what help us fight off infections. We have several different types of white blood cells. I'm not going to get into that today. That's outside of the scope of what I need you to focus on for your NCLEX. But when we don't have enough of those fighter white blood cells helping us get rid of infections, we say that our patient is immunocompromised. They don't have the immune system to really fight off infection. Now let's think about what type of patient that could be. Potentially somebody who has cancer, maybe they're going through chemotherapy and they're immunosuppressed, or they have any number of autoimmune disorder causing immunosuppression. And we're going to be really worried about this patient becoming sick. If they become ill, even just with a common cold, a rhinovirus or something, they don't really have the reserve to fight that infection like you or I might with an appropriate number of white blood cells. So we want that number to be about 5 to 10,000. Now, what about if we see tons of white blood cells, greater than 10,000? What that tells me is that my patient actually does have an infection. And it's a good thing that they have so many white blood cells. They're multiplying, amplifying, so that we can actually fight this infection off. That's what the body is doing, is trying to fight that infection with those increased white blood cells. So when we see a patient, maybe they're admitted to the emergency department with a white blood cell count of 50,000, we can be pretty sure they're also going to be febrile, tachycardic, and when we do those blood cultures, I might even see bacteria growing in their blood. So that's what we're thinking about when we're dealing with those white blood cells. Now, the last cell type that you guys are going to be evaluating in this CBC are your platelets. These are teeny tiny little small cells, and they help the blood clot. Without platelets, we're not going to be clotting very well. So we're going to be at a really high bleeding risk. When our patient has low platelets, we worry about, them just bumping their head and potentially having a brain bleed, or a small paper cut leading to a significant amount of blood loss. That's not so good. Conversely, having a high number of platelets isn't so good either. We want it like Goldilocks, not too low, not too high, just right. Because if we have a really high number of platelets, then our blood will be clotting way too much. And with too many blood clots, we could have clots going to the brain and causing a stroke, or a clot going to the heart and causing a myocardial infarction, a heart attack. So we really want the right amount of platelets, and about 150,000 to 400,000 is the right number, okay? So more than that, we're at risk for clotting. Less than that, we're at risk for bleeding. Neither of those are too good when it comes to our patients. All right, super simple, super straightforward, but some of the most common numbers that you'll see asked about on your NCLEX. So once again, make sure you memorize those numbers, but also learn a little bit deeper about what they mean and what you would expect to see in a patient with abnormalities in those lab values. The next lab test to talk about is going to be a metabolic panel. And you're going to hear a few different names for this by nurses, depending on the hospital they work at. Most commonly, either a basic metabolic panel, a BMP, or a complete metabolic panel, a CMP. And the only differences here is which of these numbers that hospital actually includes in that panel. So to avoid any confusion, I'm just going to go through everything that you could see come back on any of those metabolic panels. And I'm going to start off here with your electrolytes: sodium, potassium, calcium, magnesium, chloride, and phosphorus. Of course, all very important to various functions in your body. And I don't have time to go in depth about each of these electrolytes and what happens when we have too much or not enough of it. We'll save that for our fluid and electrolyte lecture. But I do think it's worth noting their normal values here. You have to know these. We want that sodium between 135 and 145. That potassium between 3.5 and 5. Calcium between 8.5 and 10.5. Our magnesium should be somewhere in the range of 1.5 to 2.5. Our chloride between 95 and 105. And last but not least, that phosphorus level should be greater than 2.5, less than 4.5. So again, I go super in depth into electrolytes in our fluid and electrolyte lecture. The next thing that you see come back in your metabolic panel is your glucose. You guys know what glucose is, pretty straightforward here. That amount of sugar, basic glucose, that we find in our bloodstream. Now, it's important to note that we absolutely need glucose for all bodily functions. Every single one of our cells relies on that glucose for energy. It's like fuel. But our body needs it inside of our cells, not so much in our bloodstream, right? We expect a little bit to be in the bloodstream, but too much, not so good for us. In our endocrine lecture, we discuss very in depth how glucose moves into those cells with the help of our hormone insulin. But for right now, I want you guys to know that that normal glucose range, about 70 to 100, and that it is very important to know if your patient has had anything to eat before performing that test. If they're fasting, this is where we expect it, about 70 to 100. But if I just ate like 6 Krispy Kreme donuts, my blood sugar is going to be way higher than 100. It's going to be massively elevated from all of those delicious donuts that I just had to eat. And pretty soon, my pancreas should start kicking out some insulin so that we can move that glucose into our cells. So make sure that you're aware of what your patient has had to eat or if they've eaten, so that you can correctly interpret that glucose test result. Now, if our glucose is low, we refer to that as hypoglycemia. Less than 70 is when your patient is hypoglycemic. We expect that patient to be cool, clammy, irritable, confused, disoriented, because their cells aren't getting the food that they need, the energy, the fuel. So they're not going to be carrying out their processes like normal. And particularly the brain really does not appreciate not having enough energy. So we start to see some of those neuro changes. When our glucose is high, and again, depending on when your patient has eaten, you might see different numbers here. But for a fasting patient, anything greater than 140 is going to start to concern me. And we say that that patient is hyperglycemic. We would expect that patient to be hot, dry, again, irritable. The brain doesn't really like either high or low blood sugar levels. And what that patient needs is some insulin. We need to move some of that sugar out of their bloodstream and into their cells. So make sure to watch your endocrine lecture for a really deep discussion on how glucose and insulin work. For now, memorize that normal range. All right, the next set of labs that you are going to see on a metabolic panel are your renal labs. They're going to be telling us all about the kidneys. The big three are your BUN, your creatinine, and your GFR. So what are these things? Let's talk about the BUN first. BUN stands for blood urea nitrogen. And it simply tells us how much urea nitrogen is in the blood. Well, Morgan, what in the world is urea nitrogen? All right, it's a waste product. When protein is broken down, first it turns into something called ammonia, which we'll circle back to here shortly. After being broken down into ammonia, it's converted into urea nitrogen. And then the blood carries that waste product, that urea nitrogen, over to the kidneys. And our kidneys very kindly filter it out and excrete that waste product in our urine. We don't want that urea nitrogen building up, up, up. It's like never ever taking out the trash. It gets dirtier and dirtier and dirtier. It's toxic to our body. And we rely on our kidneys to clear it out of there. When our kidneys aren't functioning so well, that urea nitrogen goes up, up, up. Our blood gets dirtier and dirtier, and we start having problems. So a normal BUN value ranges from 7 to 20, not very high. We don't want very much of that hanging out in the bloodstream. Specific values do change with age, okay? As we get older, our kidneys don't quite function the same as they did when we were young. So normal values will shift up slightly. But for your average normal adult patient, 7 to 20 is your simple range for a normal BUN that you need to remember for the NCLEX. Now, next we have creatinine. And the explanation of this is fairly similar to your BUN, all right? Creatinine is another waste product. It happens actually when we have breakdown of muscle, and that gets converted into this creatinine product. And again, we rely on the kidneys to get rid of it for us. The more that builds up becomes toxic to the body, and we know that the kidneys aren't working because they're not clearing that waste product out of our body. We want that creatinine value to be about 0.6 to 1.2. As it gets higher and higher, again, we worry about kidney damage. Now, the last renal lab I have up there for you, your GFR, your glomerular filtration rate. That's a little bit different than these first two waste products that we looked at. To understand glomerular filtration rate, first you have to know what is a glomeruli. These are the tiny, tiny little filters in the kidney. The functional unit of the kidney is called the nephron. And within the nephron, we've got these tiny little blood vessels where filtration occurs. Bad things come out. They put back the good things into the body that it needs, like fluid and electrolytes, sorts through the good and the bad. That happens in those glomeruli. Okay. So glomerular filtration rate tells us the rate at which filtration is occurring in the glomeruli. Essentially, how much blood is passing through those filters. Naturally, the more blood that's able to pass through those filters, the more bad stuff the kidneys are able to kick out, and the better our kidneys are functioning. So the GFR is the only renal lab that we want to be higher. The higher it is, the more efficient the kidneys are filtering blood. As it drops down, say to just 15, that rate of blood passing through those kidney filters is so low that the kidneys aren't able to filter and function effectively. That means that our BUN will go up, our creatinine will go up, our electrolytes are going to be all sorts of imbalanced. We're going to have fluid imbalance issues because our kidneys aren't filtering. So we want our GFR to be greater than 60. And again, you do see some variations with age here. As I mentioned, as we get older, we're going to start to see some changes. But for your adult patient, that number that you need to remember for the NCLEX, greater than 60. Anything less than 15 is indicative of kidney failure. Just not enough filtration through those kidneys, through those glomeruli. So that's what you need to memorize for renal labs. Let's shift gear and go over into the gastrointestinal system. Let's look at a couple of types of protein first, and then kind of shift gears over into the liver. When we do a metabolic panel, we look at the total amount of protein in the blood, and then we also look at a specific type of protein called albumin. So total protein first, the albumin and all the other type of proteins put together. It's going to show us nutritional status of the patient, if they are in a starvation process, or maybe they have an eating disorder, they're severely malnourished, their protein will be depleted. That's not going to be so good for us. It's also going to help us assess liver and kidney function. If the liver and kidney are malfunctioning, that protein can go down as well. Specifically, albumin is the most common type of protein that we find in the blood. It makes up about 60% of it. That's also going to help us assess nutritional status, etc. But albumin is especially important for fluid balance. Let's talk about why. In our vasculature, we know we need a certain amount of fluid to help with blood flow, hydration, fluid balance, our blood pressure. Incredibly important to all systems of our body. Again, we get into that a lot in fluid and electrolytes. What's key here with albumin is that if we don't have enough albumin in the bloodstream, we can't actually hang on to that fluid. It'll just leak right out of the blood vessels, all right? It's not gonna stay where we need it. It's gonna leak into the tissues. We call that third spacing. Our patient's going to become edematous. They might develop ascites in their belly. Their blood pressure might start to go down due to a lack of volume in their vasculature. So we really need enough albumin in our bloodstream. And that normal amount, about 3.4 to 5.4. So that's what I want you to remember about albumin and protein. Now, the next labs that I'm going to discuss have more to do with the liver. First is bilirubin. All right, this is another waste product. This time it comes from the breakdown of heme, that heme from hemoglobin that we looked at on our CBC. Red blood cells don't live forever. Their natural life cycles somewhere around 70 to 90 days. And once their time is done, the body breaks them down, recycles certain parts of them, and gets rid of waste products, namely heme. That heme gets broken down into something called bilirubin. We actually have two types of it, conjugated and unconjugated. Our bilirubin starts out as unconjugated. It then goes to the liver. And as you guys know, our liver is very important for metabolizing drugs and toxins so that they can be excreted and not build up in our body. So that's what it does to that unconjugated bilirubin. That liver metabolizes unconjugated bilirubin and spits it back out into what we now call conjugated bilirubin. So you'll hear some people say the liver conjugates the bilirubin. It takes unconjugated bilirubin, conjugates it, and now we have conjugated bilirubin. The good news about conjugated bilirubin is that we can excrete it in our stool. No problem. The body gets rid of it, we poop it out. It doesn't build up and cause problems. Unconjugated bilirubin, however, that causes issues. We can't get rid of it. It's a waste product that's stuck in our bloodstream. And as it gets higher and higher, it actually starts to cause neurological problems. You guys might remember from maybe your pediatric courses that sometimes we see this in newborns and they start to become jaundiced. Or sometimes you see this in patients with liver failure, because the liver isn't conjugating that bilirubin. It gets higher and higher, and that extra bilirubin hanging out in the bloodstream that really shouldn't be there, that's what causes our patients to get jaundiced, that yellow color that you see in the sclera, the mucous membrane on the skin. That bilirubin is the cause of that jaundice. So in adults, our bilirubin should be next to none, very low, less than 1 is the normal value that I want you guys to remember. As it gets higher and higher, you should be scratching your head thinking, what is going on with my patient's liver? Why is it not conjugating that bilirubin? So usually we see that in liver failure patients. And you'll learn in our pediatric lecture about why we see that so often in newborns. Now, another thing that the liver is supposed to help us out with, ammonia. I said we were going to circle back to this, so here we are. Ammonia is something that gets broken down, or that gets released when protein gets broken down. So remember, we eat protein, it gets broken down into ammonia, and then the liver is supposed to metabolize that ammonia, convert it, change it over into that urea nitrogen. Remember, then the kidneys got rid of that urea nitrogen for us so kindly. Well, if the liver's not working, we're in liver failure, we have hepatitis, cirrhosis, maybe our patient's in a hepatic coma, well, it's not going to be able to convert that ammonia into the urea nitrogen. So instead, ammonia will start building up in our bloodstream. This is very bad for us. That normal ammonia value, just 15 to 45, very low. As it gets higher and higher, we start to see neuro problems. Again, this is a toxin. It's poisonous to our bodies. So as it gets higher and higher, we start having changes in level of consciousness, confusion, lethargy. They might be irritable. We'll talk lots in our GI lecture when we get to the liver about what those patients look like with that high level of ammonia. But let's just say we've got to get that ammonia level down. So if you see high ammonia, again, you know you have a liver problem. Now, the last 3 are what people refer to as your liver function tests, your LFTs. And it's composed of 3 different enzymes that are found in the liver, and they're supposed to be pretty low. As we have damage to our liver, hepatitis, cirrhosis, they start to elevate. Your AST, that first one, aspartate aminotransferase. The second one, that ALT, that stands for alanine aminotransferase. And then your last one, your ALP, that stands for alkaline phosphatase. I wouldn't worry too much about memorizing exactly what those names stand for. I would know your AST, your ALT, and your ALP are all different liver enzymes. And as they go up, we worry about liver damage. So your normal for that AST, 10 to 40. For your ALT, 7 to 56. And your ALP, that runs a little bit higher, 40 to 120. Those are the normal values that you need to know on the NCLEX. All right, so that's your metabolic panel. Again, you might hear some nurses call it a basic metabolic panel, a BMP, or a complete metabolic panel, a CMP. But it's going to tell you all about those electrolytes, kidney, liver, GI system. Okay, the next lab set that we're moving into is your coagulation panel. And just like what it sounds like, coagulation is the blood clotting. This is going to tell us about how quickly the blood is able to clot. In your typical patient who isn't on an anticoagulant drug, you want their blood to form a clot pretty quickly. I get a paper cut. I actually scratched myself on my backpack the other day, and I started bleeding, but pretty quickly My blood clotted, stopped bleeding. I didn't hemorrhage to death. If our blood doesn't clot, you know, every little paper cut could be a fatal injury. So these coagulation panels tell us about how quickly that happens. Now, some patients we want to anticoagulate. We want to give them medication so that they won't form those blood clots quite as quickly. That might be a patient such as somebody who already has a clot. Maybe they had an ischemic stroke, a myocardial infarction. Maybe they have clots in their deep veins. They have a deep vein thrombosis in their calf or such. In that case, we need to anticoagulate them, give them a drug to stop that coagulation. And there's two big drugs that we talk about in pharmacology very extensively. And the first one I'm going to mention here is heparin. Okay, you guys know heparin. Anticoagulant, it's going to slow down that clotting in your blood. And the reason I'm bringing this up in relation to your labs here is that heparin works on what we call your intrinsic coagulation cascade. And that's what we're going to be evaluating with our very, very first lab here in your coag panel. That first lab is the activated partial thromboplastin time, APTT. It basically looks at that intrinsic coagulation cascade, and it says, how long are you taking here to make a clot? For patients who are not being anticoagulated on heparin, it should be about 30 to 40 seconds, give or take. If we are on heparin, we want to anticoagulate this patient, maybe to treat some clots or prevent clots. We want that time to be longer because they're anticoagulated. We want their blood to take longer to clot. So that's going to be about 1.5 to 2.5 times what their normal APTT was, or their APTT before they were on anticoagulants. So very important for you guys to know that when you're administering heparin to your patient, this is the lab that you need to monitor. And we talk about that pretty in depth in our pharmacology lecture. Now, if your patient is on a different anticoagulant, one that we call warfarin, or you may know it as Coumadin, the APTT isn't going to tell us anything about this patient's anticoagulation. And that's because warfarin acts on a different coagulation process. We call it the extrinsic coagulation cascade. So with my APTT, I was evaluating the intrinsic cascade, but my warfarin is acting on my extrinsic cascade. So that's what I need to check out to see if my warfarin's working. The test for your extrinsic coagulation cascade is twofold. First is the PT, the prothrombin time. That runs about 10 to 12 seconds. Now, you may have noticed I said about. You guys don't like about. You want very specific black and white guidelines for the NCLEX. And I do too. As a nurse, when I see a normal range, I want to know what that normal range is, what's normal, what's abnormal. What is happening with this test, though, or what happened historically, was different labs across the country, across the world, were running their tests a little bit differently. And this lab had a normal range of 10 to 13. And that lab over there had a normal range of 9.5 to 12.5. And there were slight, very slight, but still slight differences across labs. So what happened when a patient taking warfarin went from their doctor over in North Carolina to their doctor in California, and they went to a different lab and the value ranges were slightly different? Well, this created a big problem. And thus, the International Normalized Ratio was born, or the INR. This is not a separate test. It's not an extra blood test that we run. It's just a calculation based on the PT that standardizes or normalizes that PT test. So that patient can compare their INR from their doctor in California and their doctor in North Carolina, and there will be no discrepancies. It will be exactly the same, comparable. This made it much easier to manage our patients taking that warfarin. So for patients who are not anticoagulated, their blood is clotting normally, so to speak, the INR should be less than 1. When we are anticoagulating our patients on warfarin, which is most of the time that we check an INR test, we want it to be about 2 to 3. The patient should have a goal specific to them that their doctor has said. That should be in their chart, and you know, okay, the INR goal for Jimmy Bob is 2.5, and you're going to be trying to adjust his warfarin dose to get that INR exactly where his doctor wants it. So, overarching idea with these coags that I want you guys to remember: the higher the number, the longer the blood is taking to clot. If it's too high, our patient is at risk for bleeding. And that's going to be a big problem. Okay, let's move systems and talk about cardiovasculature. What are some labs you might have to monitor in the cardiac world? The first, I bet you guys have heard of before, troponin. Troponins are proteins. They're found in muscles all throughout the body, but specifically we have a lot of them in the myocardial muscle. The myocardium of the heart is the muscle tissue that makes up the heart itself, that contracts when it beats. And we don't really want to see a lot of that protein from your cardiac muscles hanging around in the bloodstream, because that means that heart tissue, muscle tissue from your heart has died. The only way that that protein really gets into the bloodstream is when that muscle dies and releases that protein out into the bloodstream. So troponins are very useful for helping us figure out if a patient has had a myocardial infarction. The higher the troponin, the more sure we are they've had a heart attack. Normal troponin levels are super low, like 0 to 0.4, hardly even there. The higher they get, anything above that 0.4, we start to be really suspicious of that myocardial infarction. Now, the other lab for cardiac that's really important for you guys to know is called the BNP. B-type natriuretic peptide is what this stands for. And this is very different. This is released from receptors that live in the right atrium of the heart. That right atrium, when blood returns to it from the body, it expands and fills with that blood. It stretches, and those receptors feel that stretch and say, hey, I'm full of blood. I've got a lot of fluid here, and I need to make sure that the heart contracts forcefully and sends that blood forward out to the body so that the body can have oxygen, nutrients from good blood flow. So when our patients become very fluid overloaded, they have a lot of volume in their vasculature for whatever reason, we get a lot of blood flow returning to that right side of the heart. That atrium is stretching, and we're releasing a lot of this BNP. That B-type natriuretic peptide is basically the messenger that says, hey, the right atrium is stretching a lot, there's a lot of fluid, the heart needs to contract really hard to move that fluid forward. So as BNP goes up, we know our patient is fluid overloaded. We specifically use this test a lot in congestive heart failure. When your heart is starting to fail and not moving fluid forward appropriately, the patient becomes fluid overloaded, and we have the release of that BNP. All of us are naturally going to have some of it, and that's a good thing. We want our heart to be able to receive that message and beat stronger when there's a large amount of fluid returning to the right atrium. But we don't want it to be greater than 125. Normal for the BNP, less than 125. As it gets higher and higher, We worry about fluid overload and congestive heart failure. All right, speaking of the heart, the next set of labs to discuss is your lipid panel. You guys probably already know about lipids. There's a whole panel that we'll get that's going to pick up these different types of lipids, though. We'll look at the total amount, and then we have 3 subtypes. The first are your HDLs, your high-density lipoproteins. The second is your LDLs, your low-density lipoproteins. And then your third is triglycerides. So let's break down, first and foremost, what your HDLs and your LDLs are. HDLs, high-density lipoproteins, are actually really good for you. We know that cholesterol is basically fatty deposits that build up in our vascular system, right? Well, HDLs actually help to clean up that vasculature. LDLs, on the other hand, your low-density lipoproteins, are simply those fatty plaque deposits that build up in arteries and veins and decrease blood flow and perfusion out to your body. So LDLs are lousy. We don't want a lot of them. HDLs are heroes. They help clean up our vasculature system and keep it free of those fatty plaque deposits that impede circulation. So I compare it to the Pac-Man game. Our vasculature are the pathways that the ghosts and the little Pac-Man guy travel through. And the LDLs are all those dots, the fatty plaque deposits blocking up our arteries and veins, reducing blood flow. HDL, your hero, high-density lipoprotein, are the Pac-Man guys. They go around through those artery and veins, through those paths, eating up the dots of those fatty plaque deposits and cleaning up your vasculature. So we want those HDLs to be high, greater than 60. The LDLs we want to be low, less than 100. Triglycerides are very low density lipoproteins. So they're even worse than your LDLs. They're another part of those fatty plaque deposits that are building up. So we also want our triglycerides to be low, less than 150. Total cholesterol, that's just the sum of your LDLs, your triglycerides, and your HDLs. And total cholesterol, we want to be less than 200. All right, 3 miscellaneous labs that I want to talk to you guys about before we shift over into the arterial blood gas. The first is your hemoglobin A1c. And I bet you guys all know that this helps us monitor treatment in our patients with diabetes. What it stands for is your level of glycosylated hemoglobin. You guys know what hemoglobin is by that point. This protein that is in our red blood cells carrying oxygen around. If it becomes glycosylated, that means that a glucose molecule has attached to that hemoglobin. And that's really going to reduce the ability of that hemoglobin to carry oxygen to the tissues. It's going to decrease perfusion, cause all sorts of problems. So when you look at your hemoglobin A1c, you see it's a percentage. It shows you the percent of hemoglobin molecules that have a glucose attached to them. We want that to be very low. We do not like it when our hemoglobins are glycosylated. It decreases perfusion. So in a non-diabetic, we expect that it'll be less than 4 to 5.6%. Very low, small percentage of hemoglobins that are glycosylated. Once a patient is greater than 6.5%, that's when we diagnose them with diabetes. And with that diagnosis, we have a target for them to keep their hemoglobin A1c under 7. Under 7% is the goal. The higher and higher and higher that our hemoglobin A1c is, means the higher that patient's blood sugar has been for about the past 3 months. Why 3 months? Remember we said that red blood cells live for about 70 to 90 days, 3 months, and then they get recycled and broken down. Well, the higher the patient's blood sugar has been over the life cycle of those hemoglobin, those red blood cells, that 3 months, the more glucose that was in their vasculature latching on to those hemoglobin proteins that are inside of the red blood cells. So if my blood sugar has been 300 to 400 for 3 months, lots of glucose has latched onto that hemoglobin, and that hemoglobin is glycosylated. So my hemoglobin A1c would be pretty high. That's why this test is very useful for monitoring the progress and treatment of our patients with diabetes. Because when we just check a blood glucose level, we see how much glucose is in the bloodstream at that very second. With hemoglobin A1c, we see about their blood sugar control over the past 3 months. So if it's really high, maybe 10, 11%, we know this patient has been hyperglycemic, and we need to maybe adjust their insulin regimen and help them better manage their diabetes. Okay, the next miscellaneous lab I have for you is something called a D-dimer. This is a pretty non-specific lab that tells us about clots. The higher our D-dimer is, the more sure we are that we have clots somewhere in our body. It doesn't tell us where, it doesn't tell us why, it just tells us to be suspicious for clots. So in a patient that maybe has DIC or some sort of ischemic disease like a stroke or a heart attack, we might run a D-dimer to see if there's a clot somewhere in the body, and that can give us some information about that. The last lab here is kind of similar. CRP stands for C-reactive protein. This is a protein that elevates in the body when we have inflammation. I don't know why we have inflammation. I don't know where we have inflammation. But if my CRP is high, I know that there is an inflammatory process going on somewhere in the body. So that just gives us another clue as to what could be going on with the patient. So both of those numbers, we want to be very low. For the D-dimer, less than 0.5. Anything greater than that, 1, 2, 5, 50, and we're pretty suspicious that this patient has a clot somewhere. Now we have to go find it and figure out more. With the CRP less than 1, as it gets higher, 10, 20, 1,000, we know, oh boy, this patient has an inflammatory process going on. Could they have an infection, an autoimmune disease? We're going to have to do further investigation and figure out why they have inflammation. But it gives us that first piece of information. All right, we're moving into everybody's favorite lab, the arterial blood gas. I have a really simple 3-step process that is going to help you guys walk through these arterial blood gases and get the interpretation of them right every time. First, let's take a quick 10-minute break since we've gone through all of the lab values. Shake it off, get a drink of water, go to the restroom. I'll see you back in 10 minutes and we'll go through arterial blood gas interpretation. All right, everyone. Hope you were able to catch a quick break, reset, and refresh so that we can review ABG interpretation. I'm going to take you through a very simple 3-step process so that you can get this right every single time. But to start off with, we have to talk about what acid-base balance is. Because if you don't understand this, ABGs aren't going to make a lot of sense to you. I said before with the lab values, it's one thing to memorize the normal numbers, but if you don't understand what they mean, critical thinking on the NCLEX is going to be pretty challenging. Same thing with ABGs. You can memorize the process, you can memorize metabolic acidosis versus alkalosis, but not understanding what causes that in the body is going to present you with a really big challenge come those critical thinking questions. So with acid-base balance, it's all about keeping the pH within a certain range, the pH of the blood, that is. The body, and especially the brain, really picky about the pH. It has to be 7.35 to 7.45. Outside of those range, and things get wonky. The brain starts to malfunction, situation goes out of control. So we have lots of mechanisms in place to keep the pH within that range. There's essentially 2 different systems that kick in here, but when the body does something to adjust the pH and bring it back into normal range, we call that compensating. The 2 systems that compensate for us are the metabolic system and the respiratory system. The metabolic system involves the kidneys. They make this wonderful buffer solution called bicarbonate, sodium bicarbonate, or HCO3. And bicarb is a base. B for bicarb, B for base. When the body makes more of it, we become more basic, which is alkalotic. And if we're not making enough of it, maybe the kidneys are down on the job, we don't have enough bicarb, we don't have enough base, we start to become acidotic. First and foremost, I probably should have even started with this. When the pH is low, less than 7.35, that is considered an acidosis. Low pH acidosis. When it's greater than 7.45, it gets higher and higher, that is alkalosis. Alkalosis occurs from too much base or not enough acid. Acidosis occurs from too much acid or not enough base. So you see, it can happen for 2 different reasons. Now, the other system that can help us compensate, change the body's pH, and bring it back into this normal range of 7.35 to 7.45 is the respiratory system. And the respiratory system does this with our handy dandy lungs that can exhale or retain carbon dioxide. Carbon dioxide is an acid. So if we hold on to it and we have lots of carbon dioxide in our body, we become more acidotic. More acid, low pH acidotic. If we need to get rid of some acid, the lungs can speed up our rate of respiration, exhale more and more CO2. And as we get rid of that, we have less CO2 in our body. The pH goes higher and we become alkalotic. So that's the foundation of acid-base balance. You really have to understand those relationships. And the summary, the meat and potatoes, so to speak, is on this slide. Your normal range for pH is 7.35 to 7.45. Less than 7.35, acidotic. Greater than 7.45, alkalotic. The normal range for that bicarbonate, B for bicarb, B for base. And don't forget, it comes from the metabolic system. If we have a bicarb problem, we have a metabolic problem. The normal range for that is 22 to 26. Great. Last but not least, that carbon dioxide, that acid, comes from the respiratory system, right? CO2, we have a problem with that. We have a problem with our respiratory system. Normal range is 35 to 45. So take just 1 minute, jot these down, write it on a flashcard. If you don't know this basic information, nothing else that I'm going to say is going to make much sense. All right. With that foundational knowledge, you're ready for the 3 steps approach. Step number 1 here, compensated or uncompensated. Now, most people don't do this till the end. I think it makes a little more sense to start here. What I want you to do is look first and foremost at the pH. Is it 7.35 to 7.45? If it's normal, you say yes, okay, maybe it's 7.37, okay, that's a normal pH. Then, following that train on the bottom, I want you to look over at the CO2 and the bicarbonate. Are they normal? Okay, yeah, that bicarb is 24 and the CO2 is 40. Okay, normal, normal, normal. This is a normal arterial blood gas, okay? Sometimes on the NCLEX, they may give you a normal one and ask you to interpret. One of your options is normal, and people think, oh, there's no way they would give me a normal ABG. This is a trick question. I don't know what I'm doing. Time to panic, and we freeze up and everything goes downhill from there. Okay, it can be normal. If all 3 numbers are normal, it's just plain old normal. More likely though, you're gonna look at that pH, it's normal. You look at your CO2 and your bicarb, and they're super abnormal. The bicarb is 30, the CO2 is 80. All right, something's going on here. This is when it's compensated. Why? Well, the pH is normal, but the CO2 and the bicarb are not. So what has happened? The body compensated. It held on to more CO2. It made more bicarb. It did something, some physiologic process, either in the metabolic or the respiratory system, occurred to compensate and bring that pH back into normal limits. So we call it compensated. It has successfully achieved a normal pH. The key difference between a compensated and an uncompensated ABG is the pH. If the pH is normal, it's compensated. Ta-da! The body did its job. It got it back into that normal range and we're happy. If the pH is not normal, you don't have to look any further. You already know it's uncompensated. The body hasn't fixed the problem yet. It's still out of whack. My pH is acidotic. It's 6.9. Whew, crap, that's not good. It's uncompensated. If the body hasn't fixed the pH, it's uncompensated. You don't have to think about it anymore. Step 1, check. So let's think about some practice here. If my pH is 7.8, compensated or uncompensated? What do you guys think? Uncompensated, absolutely, you got it right. You don't have to think about it any further. It's uncompensated. It's out of normal range, done. Okay, if my pH is 7.36, okay, I need to look further. I look at my bicarb, I look at my CO2. My CO2 is 12. My bicarb is 24. Compensated or uncompensated? Ooh, well, my pH was normal. My CO2 was super low. My bicarb was normal. Okay, my CO2 was super low. Something changed. It doesn't have to be both the CO2 and the bicarb. It just has to be one of them. My CO2 was different, but my pH was normal. Okay, this is a compensated gas. Excellent. The body changed that CO2 level to compensate, to bring that pH into normal range, and it did it. It was successful. Compensated. Okay, so you know right off the bat what's going on in the body, compensated or uncompensated. Step 2 is the easiest one. For step 2, all you have to figure out, is it acidotic or is it alkalotic? And you only have to look at the pH for this. We haven't even gotten into the CO2 and the bicarb yet. Of course, if it's between 7.35 and 7.45, good to go. It's a normal pH. So how do I know acidotic or alkalotic? This is going to be one of my compensated gases. Well, I just have to look at which side it's closest to. So 7.4 is the middle, right? That's the halfway point between 7.35 and 7.45. So if it's between 7.35 and 7.4, if it's on that acidotic side of the scale, then we have a compensated acidosis. That's going to be right here in this range where my pointer is, 7.35 to 7.4. That's a compensated acidosis. It's much closer to this acidotic side, right? Conversely, if it's greater than 7.4, less than 7.5, right here on this side of the scale, well, that's closest to an alkalosis. So then we have a compensated alkalosis. Less than 7.45 over here, uncompensated alkalosis. Whoops, I scrolled too fast. Less than 7.35 over here on this side of the spectrum, uncompensated acidosis. So again, very simple. Look at the pH. What side of the spectrum does it fall on? Low numbers are acidotic, high numbers are alkalotic. Now we're ready for step 3, the hardest step of all. Where did this problem come from? Now we have to find out, did the metabolic system cause us this issue? Or did the respiratory system cause us this issue? And we have to look at the CO2 or the bicarb to determine it. You're going to figure out which one of those matches your problem. Whatever matches, that's the culprit. So if the CO2 matches up with your pH, you have a respiratory issue. If the bicarb is the one that matches up, you have a metabolic problem. So I want to start with CO2. If the CO2 is high, remember CO2 is an acid, high amounts of acid correlate with an acidosis. So if I have an acidotic pH and a high CO2, my CO2 is the problem. I have a respiratory acidosis. What could cause a respiratory acidosis? Well, that means a situation where we have too much CO2. We're retaining CO2. So it's all these different scenarios of hypoventilation. An overdose, where the patient's only breathing 5 times a minute. Maybe COPD, any of those different types of COPD, asthma, chronic emphysema, chronic bronchitis, where the patient isn't ventilating, they're air trapping, they're retaining CO2. Too much CO2, too much acid, acidosis. A high CO2 greater than 45, correlating with a low pH, is a respiratory acidosis. On the other side of the spectrum, not enough CO2, less than 35, correlating with a high pH, an alkalosis. If those go together, you see a high pH and a low CO2, they correlate, you have a respiratory problem. That's a respiratory alkalosis. And that's caused when we breathe too much. When we have a low CO2, we're blowing off all this CO2, getting rid of it, hyperventilating, a panic attack. That's the classic NCLEX example, okay? Remember that, panic attack, hyperventilation, low CO2, high pH. That's a respiratory alkalosis, yeah? All right, so you look at that pH, you match it up, whatever it correlates with, that's your problem. All right, what if the metabolic system is causing it? Okay, B for bicarb, B for base. This is a base. So if we have too much bicarb, too much base, that causes our pH to go up, more alkalotic. Remember, more base, more alkalotic, high pH. So say our pH is 7.8. We look at our bicarbonate and it's 32. We have a lot of bicarb, a lot of base, and our pH is very alkalotic. So it correlates, it goes together. We know because the bicarb goes with the pH and it matches, it's a metabolic problem. Bicarb equals metabolic problem. High bicarbonates come from too much bicarb in the body. So what can cause that? Well, antacids, a lot of our antacids have a bicarbonate. So if patients take too many of those over-the-counter antacids, they can have a metabolic alkalosis. Renal disease, if the kidneys are not regulating appropriate amounts of sodium bicarbonate, we can get a high bicarbonate. Vomiting can cause a metabolic alkalosis or an NG tube going to suction. With either of these, we're pulling out all of that gastric content. Our gastric content is very acidotic. It has that hydrochloric acid, so we're getting rid of that. We have too much bicarb, and we might get this metabolic alkalosis. If we don't have enough of the bicarbonate, less than 22, not enough base, acidosis. So maybe we have a pH of 7.1. Ooh, that's really low. And then we go down to our CO2 and, oh, it's 35. Okay, that's normal. But then we look over at our bicarb and it's 18. We have a really low bicarbonate. Maybe we've lost lots of bicarbonate through diarrhea. When you have lots and lots of diarrhea, that lower GI tract, the intestines, small intestine, large intestine, colon, lots of bicarbonate in there. So when we have diarrhea, we lose a lot of sodium bicarb. That level gets really low, less bicarb, less base. We become acidotic. Diuretics, specifically loop diuretics like furosemide, but thiazide diuretics too, any potassium wasting diuretic can cause metabolic acidosis. That's because of how they work in the kidneys. They cause increased excretion of chloride in proportion to that bicarbonate. Those loop diuretics do, lowering the amount of sodium bicarbonate we have. Less bicarb, less base, and we become acidotic. That would be a metabolic acidosis. All right. So match up your CO2 and your bicarb with that pH. Whichever one matches, that's the problem. If it comes from the bicarb, it's metabolic. If it comes from the CO2, it's respiratory. Let's put it all together. Step 1, is it compensated or uncompensated? Step 2, is it alkalotic or acidotic? Look at that pH. And remember that if it's compensated and it's in the normal range, split the difference at 7.4 and pick the side it's closest to. And 3, is it metabolic or respiratory? Match your CO2 or your bicarb to your pH. Find out which one correlates, which one matches, and that's the culprit. If it's bicarb, it's metabolic. If it's CO2, it's respiratory. All right, it's time to practice, everybody. We're going to take it one step at a time for our first example. Step 1, is this compensated or uncompensated? What do you think? It is absolutely uncompensated. Very good job, everybody. You see that the pH is out of normal range. So you know right off the bat, you don't have to look at anything else. The body has not brought this back to normal yet. It is uncompensated. Okay, step 2, is it acidotic or alkalotic? Good job. It's alkalotic. Absolutely. It's greater than 7.45. It's a high number. Those are our alkalosis. This is an alkalotic pH. Now we have to figure out, what is the culprit? Did our CO2 cause this, or did our bicarb cause this? Is this metabolic or respiratory? Absolutely, it's metabolic. When we look at our CO2, it's normal, 35 to 45. Okay, not a problem. But then when we come down to our bicarbonate, 38, whew, that's pretty high. That's much higher than that normal range of 22 to 26. So we see that a high bicarb, extra base, too much base, has made us alkalotic. This is an uncompensated metabolic alkalosis. So what could have caused this, guys? What do you think? What is a typical patient that could present with a metabolic alkalosis? Any examples on your mind? They had an NG tube to suction, absolutely, pulling all of that hydrochloric acid out of the stomach. Or maybe they're losing it via vomiting. Maybe it's a pregnant woman who's had hyperemesis gravidarum, intractable nausea and vomiting, and she's losing all of that stomach acid. Maybe antacids, absolutely. Maybe your patient is having a bellyache and overdosing on over-the-counter antacids, absolutely. Another one is renal disease. This patient could have issues with their kidneys and therefore has caused a metabolic alkalosis. Okay, let's try this one next. Step number 1, compensated or uncompensated? Compensated, absolutely. When we look at that pH 7.6, well, 7.36, excuse me, it's within normal range of 7.35 to 7.45. So now I have to dig a little deeper and go look at that CO2 and the bicarb. Whew, CO2 of 69, bicarb of 37. Okay, I don't know what's going on yet, but the body is definitely trying to do something. They are super abnormal, and they have successfully changed that pH to be within normal range. So the body has compensated. We have a compensated pH here. Now, is this acidotic or alkalotic? Step 2. It's acidotic, absolutely. We know it's within normal range, but it's closer to the acidotic side of the scale, right? When we look at that scale, things less than 7.35 are acidotic, and 7.36 is much closer to the left-hand side there. Remember, anything less than 7.4, we kind of split the difference there. And we see that 7.36 is closer to acidotic. Now for step 3, we have to figure out what caused the problem. Is this metabolic or respiratory? Excellent. It's definitely respiratory. When we evaluate our bicarbonate, it's too high, too much base. That would cause alkalosis, a high pH. And we just said we have an acidosis. So my bicarb does not match my pH. When I evaluate my CO2, we know that normal range is 35 to 45, so 69 is high. CO2 is an acid. Too much acid makes us acidotic. And we just said our pH is acidotic. So our CO2 matches our pH. And when we have a CO2 problem, we have a respiratory problem. So this is a compensated respiratory acidosis. Now, what type of patient might have a respiratory acidosis? What's some clinical problems that could be going on here? Asthma, COPD, pneumonia, anything causing that hypoventilation. Absolutely, they're not breathing enough. They are retaining CO2, okay? We see that CO2 of 69 really high. They're retaining too much CO2. The scenario that is most commonly asked on the NCLEX, by the way, overdose. Somebody's found down, narcotic overdose, they're breathing 3-4 times a minute, very shallow. They are retaining CO2. They become acidotic. So why is their bicarbonate 37? Because that was really abnormal too. It wasn't the problem. We correctly determined that it's a respiratory acidosis. But their bicarb is elevating. Why is that? It's compensating. This is the compensatory mechanism. If our bicarb had been normal in this patient, clinically, their pH would not be 7.6. If my CO2 is 69 and my kidneys are just hanging out, not doing anything, my pH will be very low, very acidotic, 7.1, 7.2. That's probably where this patient started out. They were probably in an uncompensated respiratory acidosis. And then their kidneys woke up and said, oh my gosh, I am acidotic. I need to do something about this, gosh darn it. And they started making more bicarb. Bicarb is a base, so it started raising that pH, and it got higher and higher and higher, and now it is in normal range, 7.36. So that is now a compensated respiratory acidosis thanks to the bicarbonate elevating. So that's what we mean by the whole compensation. And now you know the 3 steps to follow to get this right every single time. You guys did great, excellent. I hope you feel much more prepared to address your arterial blood gases and to understand and know all of those normal lab values and those must-know NCLEX numbers. I go much more in depth with each and every system in our comprehensive NCLEX review course. So I'm going to spend the last few minutes letting you guys know what we have for you here at Archer Review. I have had a lot of questions about how you can access these videos on demand, how you can receive these handouts. For the free course, the handouts are not offered. And if you joined this webinar for free and you used our promo code ArcherCares, you do not get on-demand access. If you did subscribe and pay for this webinar, that does include 30 days of on-demand access. And those videos are going to be uploaded to your Archer Review account within 1 week. The course has to finish, and then we have to upload it. You'll go to your Archer Review dashboard, and you'll be able to stream on demand at any time. So if you choose to subscribe at Archer Review, our signature program here is the Sure Pass program. We call it that because we're sure you're going to pass. We've had about 60,000 students, and we have a 99% pass rate with the correct use of this program. So let me tell you about it. It too has 3 steps. I'm a big fan of a stepwise approach. I like to keep things very crystal clear. So the first step in our Sure Pass program is joining my class. I have a course called Rapid Prep. It is a live and interactive 2-day course. It moves very quickly. Those days are 10 hours long, 8 a.m. to 6 p.m. Central Standard Time, and we go through everything. That fluid and electrolyte course that I mentioned that is so important, pharmacology, fundamentals, EKGs, all the things. Then we go system by system, and we do your cardiac, respiratory, and neuro, GI, GU, endocrine. That's where we review the thyroid gland and the lab values for the thyroid hormone. We do integumentary, musculoskeletal, and then we even go into your specialty systems, peds, OB, mental health, and oncology. Throughout the whole course, I teach you my favorite testing strategies. And at the very end, we even have a session focused in on prioritization, delegation, testing strategies for select all that apply questions, and how to study and approach the NCLEX from there. So that is an intense, fast-moving course that lasts 2 days. When you sign up for the SurePass program, you get to join live. We teach that class every month. You can join if you're able to. You don't have to join the whole time. You can come and go as you please. I know some of you have work, kids, jobs, and you might not be free all day. And that's totally fine because you also get to join on demand. Those lectures, along with 50 hours of topic videos, such as the one today, are available for you to stream on demand for 2 months. That's our basic package. You can extend your streaming access up to a year, depending on when you're going to take your NCLEX. So you get all these videos on demand, including today's. If you want to access today's video on demand, but you joined for free, I recommend you sign up for our SurePass program, and you're going to get access to this video on demand. That's step 1 of our SurePass program, attending the lectures, studying your content. Step 2 is practicing that content in our question bank. We have about 2,800 questions in our question bank. They're high difficulty, high yield questions with thorough answer rationales. You first do them in tutor mode, where you start learning and practicing your content. And then you move on to step 3, and you do your learning assessments. At Archer Review, we offer you unlimited learning assessments, okay? You can take as many as you want, as long as you have questions remaining in your question bank. It's a 75-question simulated NCLEX that will give you a score that predicts your chance of passing. Once you've done 4 learning assessments and received a predictor score of high or very high, you have a 99% chance of passing your NCLEX and a 100% money back guarantee if you don't. But we're pretty sure if you follow these 3 steps and utilize Archer Review that you're going to pass your NCLEX. If you need something with even more structure, we've recently launched a new program called Intense Prep. It's everything that I just told you about, but put into a rigorous 6-week structured schedule. This is for students who have had prior attempts and have not been successful, or need accountability and structure to stay on track. We outline the entire program for you and tell you what to do every day to get you through it in 6 weeks. Not only that, but twice a week, the video lectures that you have to watch, they're going to be done in a simulated live session. So instead of you just streaming the video at home by yourself, you're going to stream it with a live tutor on the camera so that she can pause it, answer your questions, and chat you throughout the video so that you can interact and really dig into that content. In addition to simulated live, every other week, you're going to have a small group tutoring session with that personal tutor. They're going to monitor your progress, tell you how you're doing, what you need to work better on. They're going to answer your questions, teach you testing strategies, prioritization, select all that apply, really dig into those challenging NCLEX questions, and provide you personalized feedback. So this program is much more expensive, of course, because it comes with that private tutor and 2 sessions a week, another one every other week. So lots of tutoring is included. It starts at $399 for 3 months of access, and then prices go up if you want to extend that to be even longer. Now, maybe you've already taken some of these courses and you need a little bit of private one-on-one tutoring. We have 4 amazing private tutors, in addition to myself here at Archer Review, that offer private tutoring every single day of the week, morning, late night, to work around your schedule whenever you need us. It's completely individualized. So most students book 5 to 10 hours, depending on your needs and when you're testing. And in that first session, we go over your background, your history. Have you taken it before? What are your weaknesses? And we make a detailed study plan. What are we going to do Monday, Tuesday, Wednesday? We're going to plan it out with you. We're going to help you decide how many sessions you need. We're going to plan those out. And we're going to really tackle your weaknesses. So those sessions, we've got some of the lowest in the business. It's just $60 an hour. And we actually will even discount it for you if you book those 5 or 10 sessions at once. I think it's 5% off for 5, 10% off for 10. So scan that QR code. That's going to take you straight to the private tutoring booking screen. And it's going to show you our 4 amazing tutors in addition to myself. Lauren has been an OR nurse for about a decade. Valerie is a PICU nurse. She is currently on maternity leave, so she's not your best bet at the moment for availability. Lexi is our resident ED nurse. She's also the tutor for intense prep, if you're interested in joining us in that program. And Rachel is a nursing instructor. She works up at a university, I believe up north somewhere. And she works with students at her university who have maybe failed a test or at high risk of failing their NCLEX, and specializes at kind of determining what are your weaknesses, what are your strengths, and how do we need to work to get you to pass your NCLEX. So she's an expert in testing strategy, test anxiety, and coping mechanisms to overcome that and pass your exam. And she is an excellent resource to any of you who need some help with those skills. All of us also offer small group tutoring sessions, and Rachel actually offers private sessions and small group sessions specifically designed to tackle select all that apply questions, and ones to tackle testing strategy and test taking anxiety. So we cap these sessions out at just 8 students. It's still going to be very, very personalized. Of course, not as one-on-one as your private sessions, but they're much cheaper. They're only $25 for an hour. You're going to get individualized attention from that tutor in whatever topic that session is for. As I mentioned, Rachel does the select all that apply, the testing strategies, test anxiety. I do sessions like we just went over ABGs. I do sessions where we work through a lot of practice ABGs, and I help figure out, okay, where are you going wrong? What do we need to address? We do some on EKGs. I have a small group on EKG interpretation tomorrow. In case you aren't so good with the EKGs and you need a little tune-up, I can do an EKG session with you. Tomorrow you can join my session. I think it is at, let's see, what time it is tomorrow, 11 my time, which is a 1 p.m. Central Standard Time that we have that EKG session tomorrow. So again, scan that code and it's gonna take you, let me show you, right to this page when you scan that QR code. If you're not scanning, just go to archerreview.com and click private tutors up at the top. When you scroll down, you see all the tutors. So you see me, Lexi from Intense Prep, Valerie, I mentioned, is on maternity leave, Lauren with that operating room background, and then our nursing instructor, Rachel, who specializes in those testing strategies. So for example, if you're interested in that session, you just click book now for Rachel. If you want to book one of her one-on-one sessions, it's defaulted to that. And you'll see you can do the scroller over here to pick however many sessions you want, and it'll show you the total price over on the right. So $60 for one session. If I want to do 5 sessions, see, I get that discount and the price comes down. So let's see what Rachel has open for those one-on-one sessions. You click book now. Look, today she's pretty booked up. Tomorrow she's pretty booked up. But look at all these slots that you've got over here. So Valentine's Day, you can do a little session over here. Say that I see this one in February that I really like. I can just go ahead and select it by clicking over here. That's going to be my first session. And then I'll just keep clicking until I get all the sessions that I want, click proceed to pay, and go ahead and book those sessions. I'm going to remove those from my cart so that you guys can go book them up. But let's say that you prefer a small group. Let's show you Rachel's small group availability. If you scroll down on her page, toggle over here to small group, and you'll see that price change. Remember, it's just 25 bucks. Choose your time slots, and let's see what she's got. She has 3 open in February. On the 5th, she has select all that apply, as well as on the 9th, another select all that apply session. Those are super for really drilling down on that testing strategy, because we all know how challenging those select all that apply questions can be. And then on the 25th is when she has that study skills and test taking anxiety session. So again, just click it, proceed to pay. Something important to note is that it's going to show up in your time zone. So for me, this session is showing up at 1 p.m. I'm in Pacific time. Rachel, I think, is in Mountain time, so it's 2 p.m. for her. If you're in Central time, that's 3 p.m. So you don't have to worry about any time zone math. It's just going to show up in your time zone. So we're all there on that private tutoring page. For example, if you wanted to book my EKG session tomorrow, if you have trouble with those EKGs, you can click on me, go over to that small group and choose your time slots. And then you'll see that my EKGs, I have tomorrow at 9 a.m. Pacific, 11 Central, and you can just book that right there if you want to join that session. So again, scan that code whenever you have some time. It'll pop you over to that website and get signed up for anything that we can help you with. I'll pause here because I think I've gotten some questions about these different products and tutoring. I want to make sure that I answer everyone. So give me one moment to toggle over here and I'll see. Some questions about the differences between our course and our question bank for the RN program versus the PN program, because of course those are different question banks. And in the PN question bank, there are less questions, about 800. The prices for those programs are less to reflect the difference in number of questions we have available in that question bank for you. This student says, you know, I'm a repeat test taker. I've tried this, I've tried that. What else can I do? For students who have failed multiple times, my best recommendation for you is that intense prep program that we talked about earlier. Intense prep is really designed for repeat test takers for 2 reasons. The first is that structured schedule. It's going to make sure you cover everything. The second is for that feedback. Your personal tutor is actually going to be able to see your assessments and say, okay, this student really has trouble with prioritization. And they're going to be able to talk to you about that and work on that skill with you. It's very helpful if you have failed in the past to bring your, you get afterwards that candidate performance report, that CPR. Show that to your tutor. They can look at it and see, ooh, management of care is a struggle for them. I want to go over this, this, and that, and then we're going to do these practice questions. That's going to be a really targeted approach to helping you get there, right? If you don't get feedback, it's sometimes hard to know what you need to improve on. Private tutoring is another really, really beneficial service for students who have failed. Maybe you don't want to commit to the 6 weeks intense prep, too expensive. Book some private tutoring. Bring that candidate performance report to your private tutor. Say, hey, what the heck am I doing wrong? They can look through it with you, work with you, and figure out what in the world you need to do. How much is the SurePass program? Excellent. Our prices vary depending on how long you would like to have access, and of course, RN versus PN. Let's look at the RN program here. When you click on courses, go over to your appropriate course, scroll down, you're going to see discounted combos is what it defaults to, and that's where you will find the SurePass program. Scroll down, it's going to give you some info and then some different prices. I want you to go down and find the SurePass combo. NCLEX Rapid Review On Demand and QBank SurePass combo. It's on sale right now for just $119. And that's going to give you access to the question bank for 6 months and access to the on-demand videos for 60 days. So it tells you right there the validity, how long you're going to have access. You get a lot of value with that SurePass combination. If you need to study for longer, we've got another SurePass combo that's going to be active for a whole year, $199. Read all of the different things it includes here. If you need to study for shorter, then we've got other options up here for you. So read what they include and pick the right combo for you. So from $89 up to $199, anywhere in that range. Can you repeat again about the private $60? Yes, private tutoring, that one-on-one super custom NCLEX tutoring, $60 an hour. I showed you over here all of our different tutors that you find up on archerreview.com at private tutors. They have availability every single day of the week at all sorts of various times. Click on their schedules to look at their different offerings. You can look at Lauren, for example, choose her one-on-one. She's got slots, look, all slots, pretty much every day of the week. February schedule is getting ready to be finalized. She usually does evening slots for our students who have jobs and kids and responsibilities during the day so that you can study later at night. And for students in varying time zones, we try to kind of spread them out. Another thing I'll mention with that private tutoring, if you check all of the different tutors' schedules and you're like, none of this work for me, read through their bios, see who you're interested in working with, and shoot them an email. Got all of our emails right here for you. It's just our first name at archerreview.com. So I'm Morgan at archerreview.com. Rachel is Rachel at archerreview.com, etc. Right? Shoot them an email. Say, hey, I see you're booked up, or you don't have any openings, or your openings don't work for me, but I really need some one-on-one help. I read your bio. I'm interested in working with you. Here's when I want sessions. Talk between the two of you and figure out what mutual times work. They can then open those sessions up and you can go snag them up, okay? 5, 10, 15 sessions, whatever you want, okay? Also scan that code for me and make sure to give us a follow on Instagram. We're Archer NCLEX, because I post openings for the private tutoring, and I even do giveaways once a week where you might get a free 1-hour session. Somebody yesterday just won a free 1-hour session. So make sure to follow, participate in those giveaways, tag your friends, and you might get some free private tutoring. Anna Marie asks, how can I book the intense prep? Excellent, excellent question. It's going to be quite similar. When you scroll over courses, you see that intense prep is right down there. It's that last option under nursing. So it's going to take you to that page. It's going to show you your tutors, the schedule, different stuff. It says if you're looking for different times, click here. It walks you right through it. It shows you when all of the upcoming sessions are so that you can see when our live simulated sessions are happening. And then if you scroll all the way to the bottom, you're going to see our basic 2 options. The access for 3 months is $339, and the access for 5 months, or 6 months, excuse me, is $599. So maybe I want that 6-month program. I'm going to click buy now. type my info. As soon as you sign up, you're going to get an email with lots of info about how you're going to be able to join all of these live sessions. You're going to get a schedule. You're going to get an activity booklet. You're going to get a video guide. You're going to get a lot of stuff. Really, this program is expensive, but the value proposition on how much you're getting for that $3.99 is insane. You're getting a lot of stuff. I mean, this is a lot of private or small group tutoring and live sessions for that amount. Vanessa asks, maybe some of you already have that rapid review combo. And she said, you know, sometimes she looks and she watches with the new videos and the handouts were from the previous. Yes, Vanessa, those handouts do get updated regularly by our support team. And I believe that they were updated relatively recently. So check back in those handouts, those videos. Everything on our site is always being updated as we put new content out there. If we book one-on-one coaching, can we choose the topic that we want to discuss? Yes, one-on-one, totally individualized. You're the boss. You're going to tell your tutor exactly what you want to do. What program would be recommended for me if I take the NCLEX in 1 month and I'm a first-time test taker? Anybody who's a first-time test taker, I recommend the SurePass program. Intense prep is great, but you probably don't need it if you're a first-time test taker, to be honest. The SurePass program, that's our signature program. That's going to be my recommendation if you're a first-time test taker. You can definitely do it in 1 month. We even have a schedule uploaded as like a recommendation of what we recommend doing every day if you want to finish the course in 1 month. Of course, it's just a recommendation. You can do whatever works for you, but it's certainly doable in 1 month if you're committed and you're going to work the way through it. If you've already purchased the combo and it's going to expire and you would like to renew it, you can email support@archerreview.com and they will help you out with getting that renewal set up. Absolutely. All right, Shaw asks, can I go over the steps to use the review? Yeah, the SurePass steps are first, do the review that content, take that rapid prep course, watch those on-demand videos. Step number 2 is do your practice in your question bank. And step number 3 is do your learning assessments to predict your chance of passing. Remember, I want you to get 4 scores of either high or very high to ensure that you have that 99% pass rate on your NCLEX. Let's see. If I purchase one of these programs and decide I want more time, maybe I purchased for 3 months, but now I want to extend it. Do I have to repurchase the whole thing and pay full price, or can I just pay the difference? Well, you just want to email support@archerreview.com so that they can set up a renewal for you. You don't necessarily have to pay the full thing again. I would not recommend that. I would just recommend reaching out to our support team at support@archerreview.com. I'm actually going to put their email down in the chat here, support@archerreview.com. If there's any questions I haven't been able to get to, any technological things about your account, renewals, etc., you're going to get the quickest response by emailing our team at support@archerreview.com. It's hard for me to get to, you know, all 200 of you with all of you have at least one question. So if there's anything outstanding, they are going to be your go-to guys and gals to get your account straightened out and answer anything remaining. Will there be any more free lectures anytime soon? Probably. The best way to find out about them is to follow us on Instagram. So scan that QR code for me, give us a follow. Instagram and Facebook, of course, we're on Facebook. gotta be on Facebook, is where you're gonna find out about those courses. They're surprise little free courses. You don't know when they're coming unless you follow us, and that is where we will put the link to sign up for those free courses. Remember, if you sign up for free, you're not gonna get on-demand access, or you're not gonna get handouts. If you want to have the on-demand access, the handouts, the notes, you want to sign up for our SurePass program like we've been talking about. Diego says, I have a better understanding of ABGs. Thank you so much for this webinar. Thank you, Diego. I'm so glad that you guys joined today. Awesome. Do you have any live courses other than SurePass and Intense Prep? Those are our two signature live courses. And then, of course, the SurePass has that 20-day long lecture that I like to call Rapid Prep. That's kind of our signature live class. And then in the Intense Prep, you have lots of live classes. You know, you have those simulated lives where you watch my video with an instructor on the line answering your questions. And then you have those bi-weekly group tutoring sessions. And then the other live courses, of course, are the small groups, the private tutoring sessions. Those are, of course, live and interactive because they're, you know, small and they're, you know, really focused. All right. Sounds great, everybody. We are at the very end of our lecture. I'm sure there are some questions I've missed, and I do apologize. I've tried my very best to get through as many as I can. Please feel free to email our friends at support@archerreview.com for anything I wasn't able to get to at all. They are super helpful in getting your account renewed, helping with your subscription. If you're curious about what you should sign up for or not really understanding how to study, I highly recommend reaching out to them. Or, of course, one of our tutors. They are nurses, people who have been nurses for decades. They've taught nursing school courses. They're great instructors that know a lot about how to test and how to pass this NCLEX. So reach out to them, say, you know, hey, this is my background. I really want to work with you. Let's work something out. And they're going to set up some sessions for you and get you squared away. Again, make sure to follow us on Instagram. Maybe you can win one of those giveaways and even get some free private tutoring. For those of you who are signing up for the SurePass program, the next time that we are running our live 2-day course, that Rapid Prep, is on March 3rd and 4th. So I really hope to see some of you there. Please feel free to shoot us an email with anything outstanding, and we'll do our best to get right back to you. Most of all, I hope that you enjoyed the lecture. I hope that you have a better understanding of ABGs like Diego does, and you're confident about your lab values and those must-know numbers on the NCLEX. That's really what I hope that you got out of today. It's been fun working with you. I hope to see you next time. Again, I'm Morgan with Archer Review, and happy studying, everyone.